Okay, we're going to go ahead and get started. So it's my pleasure this morning to introduce Dr. John Brush. John was raised in Richmond, Virginia, went to UVA for medical school, Vermont for residency, where apparently he met Al Sanusis, who was a student at the time. And then he came to Yale for cardiology fellowship. And I had the good fortune of being a co-fellow with John and Woody Lee. Is Woody here? So Woody was also in our fellowship group. And back then it was a 2-year fellowship. So John was here for a couple of years and really had an impact in a very short time on the institution. While he was a fellow, he published a seminal paper in the New England Journal of Medicine which showed that initial electrocardiogram was highly predictive of subsequent events in the hospital in patients with chest pain. It really changed the paradigm of how we treated patients. Some of you who are of a certain generation remember the term soft Romy. So a soft Romy was someone who had chest pain who was admitted to rule out MI. And the CCU used to be loaded with soft Romies. Very different situation from now. I can attest to that as I attend in the CCU this month. And so John's paper basically said if the initial ECG is normal, the chance of any adverse effect, adverse complication in the hospital was almost zero. And it basically ended the policy of admitting soft Romies to the MI. And of course, together with rapid point-of-care troponin, patients then went to the floor, and now, of course, they just go to an observation to the chest pain unit. John, while he was here, I remember three things about those years. One was that John was a great co-fellow. I was in the CCU, had never been in the cath lab. My attending told me to put a swan in a patient who was on a vent and to do it from the groin. And I got into the right ventricle and got into trouble real fast. And so attendings tended to be not on the scene in those days. And so I called John, and John bailed me out. We got the swan in place. Also remember John's passion for skiing, a passion that we shared. Couldn't figure it out since he was born in Virginia, but this time in Vermont obviously had a big impact on him. So he went to the NIH, where he worked with Steve Epstein and Marty Leon, Barry Marin, and there did, again, some very impactful work studying microvascular disease and endothelial function, really ahead of his time. And I Google scholared him and found one of his papers in the New England Journal. It's been cited almost 3,000 times on endothelial dysfunction, which is kind of an indoor record, really amazing. He then went to BU for a few years, became an interventional cardiologist, and moved back home to Virginia, where he's had a remarkable career in a practice now at Sentara Hospital. He's a professor at East Virginia Medical School and has had a long-standing interest in quality and decision-making, the topic of his talk today. He has had a leading role in the American College of Cardiology around quality and has interacted with some of you in the audience. And it really is my distinct pleasure to welcome John back to Yale.
Thanks, Larry. Is the microphone on now? You can hear me, I hope. It's such an honor and privilege to be back here. My second day of a fellowship, I was standing right here in this auditorium presenting at CAT conference, and what a thrill it is for me to be here today to talk to you. I want to talk about improving quality by improving the quality of medical decision making. But before I start my talk, I just wanted to show this picture. This is the Yale Fellowship class in 1983. And you can see a couple of things. There's some peculiar things about this picture. I was on call the night that we had this banquet, and so I wasn't there. And neither was Woody Lee. And so somehow someone got the idea that we would be put back in this picture. And so I think it might have been Barry Zaret's secretary or somebody cut pictures of us out and very cleverly put them in this photo. You know, tucked back in. We've got Woody over here hovering, and we've got me over here. Woody's looking like a future dean, I think. But I'm looking kind of ridiculous, actually, over here. Hopelessly naive, very young. And my friend Larry is standing next to me saying, "John, this is the Yale Club. Jackets are required here. What are you doing?" So, you know, seeing all the friends here in this picture, and it just brings back so many memories of Yale. As Larry said, I was only here for 2 years, but this place made an enormous impact on me, on who I am as a professional, as a cardiologist. And so I just wanted to bring that up and say thank you. Thank you to all who were here at the time and who I interacted with, because it was a real privilege to be here. Just first, my disclosures. I wrote a book called The Science of the Art of Medicine, A Guide to Medical Reasoning. And just for full disclosure, the iBook is free. I received a grant from the Centera Foundation, so I've been able to print a bunch of copies so I can give out hard copies for free, but I do receive royalties from Amazon sales. The purpose of this thing wasn't to make money, but I do receive some royalties. This is what I want to do today. I want to, first of all, tell you how I got involved and interested in quality and medical reasoning. I wanted to tell you a little bit about what I learned and what's in my book, just a little bit of what's in my book. I wanted to tell you about 2 studies that I've recently completed related to medical reasoning, specifically to diagnostic reasoning. Talk about some of the practical implications, and if I'm efficient enough, we'll have time for questions and discussion at the end. So in 2001, I was asked to participate in the ACC task force on quality. George Beller was president of the ACC in 2000, and in 2001, the year after his presidency, he led this task force. It became known as the George Beller Task Force. And so I was asked to be on this task force somehow or another, and I was then asked to chair one of the work groups of the task force that was meant to try to figure out how we can translate quality into practice. Ends up Harlan Krumholtz was on my work group, and so I had to sort of bring myself up to speed in the quality world and what have you. And this task force on quality ended up morphing into a standing committee at the ACC called the Quality Strategic Directions Committee. Ralph Brindis was the chair of that committee for the first 3 years, and then for the second 3-year term, I was the chair of this committee. So again, Harlan Krumholtz is on my committee, Ralph Brindis, Rob Califf, Elliot Antman. These people are on my committee, and so I thought, my gosh, I need to really get myself up to speed. So I went into this reading frenzy on quality, reading Duran and Deming and Berwick and other these books on quality to bring myself up to speed. And so as I started thinking about quality, I started thinking about, well, what's the root cause of poor quality? Oftentimes it's not systems problems, oftentimes it's poor decision making. And so the Institute for Medicine came out with this book, To Err is Human, which talked about some of the human errors that are made and that impact on quality. And it led me to this other book called Human Error by a guy named James Reason. James Reason, a perfect name for someone who's a cognitive psychologist. He's a cognitive psychologist at University of Manchester. And this really introduced me to the field of cognitive psychology. This is a field that is meant to study how we make decisions. And yet, nowhere in my medical school training did I receive any instruction on how we make medical decisions. There seemed to be a disconnect. And so I then went into a second sort of reading frenzy about cognitive psychology and probability theory and logic. And I started telling my wife, I said, I could write a book on this stuff. And after, I said that over and over again, I actually did. And so this is the book on the left, The Science of the Art of Medicine. I asked Harlan to write the foreword, and he did that. And so then he asked me to co-author the chapter in this most recent Brownwald on quality of care and medical reasoning. And so the third chapter in Brownwald is by Harlan and myself. So the main problem is that there's a lot of clinical uncertainty out there. This really hit me when I went into private practice, because in private practice, you are utterly alone. You're utterly alone in the middle of the night. And so the uncertainty really becomes, I think, more apparent. Philosophers talk about two types of uncertainty: epistemic uncertainty, that's related to the knowledge or the lack of knowledge. We have lack of knowledge about the true state of our patients oftentimes. And there's a lack of knowledge about medicine in general. We're just scratching the surface of the science of medicine. But there's also this stochastic uncertainty. It's related to the vast variation that we deal with. There's 7 billion people on the planet, and each one of them are different. Each one of them will present differently. And also the likelihood of single events. We take population statistics and try to apply them to individual patients. And so into doing that, you have to make this mental flip from a frequency notion of probability to a subjective notion of probability, thinking about individual patients. There was an article that was published by Tricocci and Califf and others at Duke that came out in 2009, where they looked at the 16 current cardiology guidelines. They looked at the 2,711 guideline recommendations, and among those guideline recommendations, only 11% had evidence level of A. 48% had level evidence of C, so meaning based on opinion. There's a cognitive psychologist who writes a lot about intuition. His name is Gary Klein. He says that approximately 95% of decisions that are made in general, by people in general, are made through intuition. And so if you looked at this, the Tricocci study, and you looked at how many of the decisions are made by evidence-based medicine amongst the guidelines, but then the guidelines, they don't cover everything in medicine. And so if you kind of look at it and multiply it out, about 95% of our decisions in medicine are made through human judgment, through intuition. So I really became very interested in this topic of skilled intuition. Skilled intuition is intuition that's informed by knowledge. And so cognitive psychologists say we use skilled intuition to do one of three things. We classify, we estimate, and we choose. There's an article that appeared in the Annals by someone named Jordan Cohen many years ago called Remembering the Real Questions. And he said, patients come to us asking us three basic questions. Doc, what's happening to me? Doc, what's going to happen to me? And Doc, what can you do for me? So we use skilled intuition to answer those three questions and provide the deliverables of medical care. We classify patients into diagnoses. We estimate their prognosis, and we choose their treatment. So we use skilled intuition all the time. Intuition is not guessing. It's just sort of in lay people talking about intuition, it's just sort of thought about as intuition. But cognitive psychologists use the word differently. And so one of the people that started the field of cognitive psychology or behavioral economics is this guy, Herbert Simon. He won the Nobel Prize in economics because he really started the whole field of behavioral economics. He said this: the situation has provided a cue. This cue has given the expert access to information stored in memory, and the information provides the answer. Intuition is nothing more and nothing less than recognition. We use intuition all the time, and skilled intuition all the time in medicine. So there's another way of looking at intuition. You could say that Sir Isaac Newton is probably one of the greatest scientists that ever lived. He taught at Cambridge, Trinity College, Cambridge, and another person who taught at Trinity College, Cambridge was John Maynard Keynes, the famous economist. At the 300th anniversary of Sir Isaac Newton's death, John Maynard Keynes gave a talk. And in this talk, he said about Newton, he said, "I fancy his preeminence is due to his muscles of intuition being the strongest and most enduring with which a man has ever been gifted. I believe that Newton could hold a problem in his mind for hours and days and weeks until it surrendered to him its secret." So intuition is not, it's not guessing. Intuition is a gift, and we use it all the time in medicine. So if we are able to calibrate it, if we're able to use it, if we're able to train ourselves to develop good habits so that we use intuition well, I think that that's an important thing that we should be thinking about in training and also in our ongoing practice. When we err, the intuition fails. We either jump to conclusions, we distort probability estimates, or we use biased judgments. So how can we improve? The quality improvement guru, W. Edwards Deming, said, if you can't describe what you're doing as a process, you don't know what you're doing. Well, we don't really talk about the process of medical reasoning and particularly diagnostic reasoning. Basically, we think to do. In cardiologists, we do things to people. And so it's important, if we want to produce good outcomes, it's important to think about how we think because that thinking produces results. So you can think about, we can examine our thinking through a number of ways. One, we can examine our own personal experience. But of course, that's anecdotal. We can look to philosophers. And there's a philosopher of science, Ian Hacking, that I really like. And he sort of led me to recognize the school of American pragmatism started by Charles Saunders Peirce and William James and John Dewey. They came up with this thing called the pragmatic maxim. What counts are the practical consequences of our thinking. So for a practicing physician, this really, really starts to make sense. William James said this. He said, there can be no difference anywhere that doesn't make a difference elsewhere. That could be the motto of outcomes research and clinical research. If it doesn't make a difference in the real world of practice, it doesn't make a difference. We can also look at cognitive psychology to examine how we think. And so if we think to do, then what we do is an indication of what we are thinking. It's really the basis of cognitive psychology research. What they do is they make they do randomized controlled trials. They make small changes in one arm of the trial. They see how what people do in response to the small changes, and they sort of work backwards to figure out what they might be thinking to produce results. That's the whole way that cognitive psychology research has progressed. The other way of looking at what we are thinking is something called protocol analysis. We ask people, what were you thinking? Well, there's this article in 1977 by Richard Nesbitt from University of Michigan and Timothy Wilson, who became the chief of psychology department at UVA, that it said that people's introspection about what they're thinking is very unreliable. When you ask somebody what they're thinking, about 30% is true, but there's a lot of justification and rationalization that you hear, and so that's not necessarily such a good way of understanding what people are thinking. And so the experimental methods of cognitive psychology have really worked well. One of the things that cognitive psychologists talk about is this dual process theory, where we have two different ways of thinking called System 1 and System 2. System 1 is the intuitive mode, and System 2 is the analytical mode. System 1 is fast and automatic. System 2 is slow and deliberate. System 1 is like driving your car. You get to your destination, you can't even remember how you got there because you were doing things sort of on automatic pilot. Whereas System 2 is like parking in a tight space. Every little move is very deliberate. System 1 uses association and love stories. System 2 uses explicit beliefs and reasoned choices. System 1 sees the forest. System 2 sees the trees. System 1 can be biased, but it's often right, and it's often very useful, whereas System 2 it can be slow, and it can't handle uncertainty. Therefore, it's really oftentimes not available for making rapid decisions in clinical settings. And so we use System 1 to make rapid decisions all the time. This was the subject of Thinking Fast, Thinking Slow, a popular book by Daniel Kahneman. So it's good that we have two types of systems of thinking because there are two types of problems in the world, according to William Simon. There are unstructured problems and structured decisions. So when a patient comes to the emergency room, it's an unstructured problem. They're throwing all kinds of information at us, and it's a little bit like a puzzle that's with the pieces of a puzzle. We have to use non-analytical reasoning. We have to use heuristics to try to organize all of this information and to try to figure what's going on. So just like with a puzzle, you look for the edge pieces. You sort by color. There's certain heuristics that you use to solve a puzzle. Well, we have certain ways that we solve the puzzles in clinical medicine as well, the organized history and physical, for example. What we're trying to do is we're trying to turn the puzzle into sort of a series of structured decisions. Yes or no? Is it acute myocardial infarction or not? Is it coronary disease or not? Is it pulmonary embolus or is it not? Is it dissection or not? So that's how we work through diagnostic testing. So I want to talk about the process of making a diagnosis. Years ago, Arthur Elstein, Jerry Kassir, Jeff Norman's group, they independently came up with, they examined how expert clinicians make a diagnosis, and they found that it was a two-part process: hypothesis generation and hypothesis testing. Ends up, hypothesis generation is using that non-analytical reasoning, and hypothesis testing is using the analytical reasoning, so it's using both system 1 and system 2. Arthur Elstein found that, that expert clinicians, within seconds to minutes of diagnostic encounter, have 3 to 5 diagnostic hypotheses in their head. Many times, primary care physicians will have the diagnosis in their head just based on the chief complaint alone. So expert clinicians are generating those hypotheses. If you don't think of it in the first place, you'll never come up with a diagnosis. So I became interested in this early hypothesis generation, and I reached out to Jeff Norman. And I gave him a copy of my book, and I actually got to know him. And we ended up writing a review paper on the non-analytical reasoning, which was in the American Journal of Medicine 2 years ago. Ends up there, the way we generate hypotheses depends upon the stage of training we're in. Medical students, they use mechanistic or causal reasoning, and it ends up, it's kind of a clunky thing to watch. And we all remember at those days, it's slow, and it's often incorrect. As residents gain experience, they develop something called illness scripts, which are sort of a prototypical example or concept of what an illness is all about. But as experts gain increasing expertise and experience, you gain experiential knowledge in the form of exemplars. When you see an object and you label that object and you put that object in long-term memory, it's called an exemplar. And so what we do is we fill our heads with exemplars, and then we draw on that experience. We have a fallback mechanism. If none of that works, we have a fallback mechanism called abductive reasoning, which is basically reasoning towards the most plausible hypothesis, which is sort of falling back on analytical reasoning. So when you look at this picture, you know immediately what you're looking at. You don't go through a rule-based algorithm to figure out that these are chairs. You just know because you've seen a bunch of chairs before. And ends up, cognitive psychologists think that we use the same mechanism to diagnose patients. You've seen a bunch of patients with MI or sepsis or whatever, and when you go to the emergency room and you see that person with sepsis, you just know, or that idea pops in your head. It's a hypothesis, it's not a conclusion, but the idea pops in your head. And it pops in your head effortlessly and immediately, instantaneously. The effort is on the front side, putting all that information into your head and gaining that experience. But calling up exemplars is typically effortless. The file cabinet that you have in your long-term memory and the thickness of those files of exemplars gives you an intuitive sense of the base rates and the range of variation of a diagnosis. And so we play on this when we take care of patients. So there's another theory. There's exemplar theory and there's prototype theory. Exemplars are an instance-based model. They're immutable examples that are in your long-term memory. There's no abstraction involved. Whereas prototypes, it's a weighted set of features, a summary description, a concept, similar to the illness script that I described. People argue which one we use. Most of the time, the recall is so rapid that leads people to think that exemplars are the primary way that we do this. And so I got interested in this, and I had an opportunity to think about this because I participated in the Virgo Registry. I was a local PI in the Virgo Registry. The Virgo Registry is from Yale, and you'll see names here that this is the initial paper that described the study. It was a NIH-sponsored registry that looked at patients, particularly young women, 59 and under, with acute myocardial infarction. And so this study has produced many very important papers about how young women present with acute myocardial infarction. They enrolled 3,501 patients with both young women and men as a control group. And so it offered an opportunity to look at how patients present with acute myocardial infarction. And so I had the pleasure of working with Rachel Dreyer, a statistician named Eric Green, and also Harlan on this study. Harlan agreed to send me a de-identified cut of the data so that I was able to start looking at this, and we were able to start looking at this. So patients, let me just give you the background. The patients present as individual patients. And so I see them in the emergency room, and you see them in the emergency room or in the clinic, and you store them as a memory as exemplars. So an exemplar then is a mental representation of a specific phenotype. So it seemed interesting that nobody really looks at the specific phenotypes. They look at how symptoms line up at the population level, but not at the individual level. So my thought was, how do features combine as specific phenotypes at the individual level? And do those features combine differently in women than men? If they do, maybe that explains why it's more likely to miss a diagnosis of acute myocardial infarction in women. And do the features combine differently in various MI subgroups? So we were able to look at this in 3,501 patients because with this registry, we had nurses go in and interview every single one of those patients during their index hospitalization. They took detailed interviews where they systematically recorded what symptoms these people had. So they had information on 10 different symptoms on every one of these people. There was no dropout of information. If you abstracted it from the medical record, you have dropout, but we had no dropout here. So theoretically, if you've got 10 things, there are 1,023 different ways that those 10 things can combine as individual phenotypes. So it's like snowflakes. And ends up the Virgo already reported out at the population level, there were differences between women and men. Women were more likely to have indigestion, nausea, other type pain, palpitations, shortness of breath. There were differences at the individual level. The four most common diagnoses in women and men were chest pain, radiation, diaphoresis, and shortness of breath. And those four things really sort of make the prototype of acute myocardial infarction. So at the individual level in the Virgo database, there were 488 individual unique symptom phenotypes. These are the top 25. The most common was chest pain alone, but it only occurred, chest pain alone only occurred in 6% of patients. Generally, chest pain occurred with some other symptom. But it was a variety of different symptoms. That prototype, the prototype of acute myocardial infarction that we see in textbooks, chest pain with radiation associated with shortness of breath and diaphoresis, that specific phenotype occurred in only 1% of the Virgo registry patients. And so it may be that the way we're teaching it through prototypes, we may be teaching stereotypes, actually, and we're certainly not teaching phenotypes. One of the things that phenotypes tell you is that there's enormous variation in how patients present, and we should appreciate that. There were more phenotypes in women than men. There were 426 total phenotypes in women and 280 total phenotypes in men. And here are the top 25 by sex. The top two are the same, chest pain and chest pain with radiation. The top six were the same but in different order. And 6 of the top 25 didn't match in males and females. There were on the average more symptoms among these top 25 in women than men. And men were more concentrated in the top 25 phenotypes than women. So this started to give us an idea that something is going on here, that women are different in terms of the broad spectrum of phenotypes that they present with. Here's just a slide that shows visually the difference between women and men. Now, by design, the Virgo registry signed up patients with a 2-to-1 female-to-male ratio. They were interested in young women, and so they concentrated the effort on young women. So the width of these, the vertical dimension is twice as large for females than males, representing the fact that there was a difference in the populations that we studied. But the width of each one of these stripes represents the proportion of the patients who had these particular phenotypes. And you can see, you can just see that the distribution of phenotypes is different in women than men. Here's chest pain, the most common. The second most common is chest pain with radiation. Here's that prototype here, just a small slice of the total number of phenotypes. So because of the 2-to-1 female-to-male ratio, we had to develop some kind of sophisticated techniques for looking at this statistically to see whether the difference in phenotypes was actually a difference, or was it just simply due to the fact that we had twice as many women as men in the population that we studied. And so we used Monte Carlo permutation testing, where we randomly permuted sex to create 99,999 data sets under the null hypothesis that the whole difference was just due to the difference in the enrollment ratio. And so in doing that, we created this, this empirical distribution. And so if what we found was outside of the 95th percentile, we would know that the p-value was significant. And in fact, the difference between women and men, as I already told you, was 146 phenotypes. And that, in fact, was statistically significantly different than the median difference that would be expected under the null of 110, just due to the difference in sample size alone. We looked at it a different way. We did repeated sampling, where we took repeated samples with a bootstrap sample size of 500. We took 100,000 subsamples. And so in that case, you know, the number of women and men in the subsamples were equal. And so this is how this was distributed. And on the average, women had significantly more phenotypes than men doing it this way. And so it appears that women, despite the fact that there was unequal sample size, and no matter it wasn't really necessarily a problem with the Virgo database, no matter what database you look at, they're going to be unequal sample sizes. And so if you're looking at phenotypes where the phenotypes may be a long string of very, very rare phenotypes, if you cut the sample off, you'll cut off the tail, and you could, you know, just differences in sample size could affect your statistical evaluation. So we had to use these two methods to try to get around this. What we found is 47% of the interview symptom phenotypes, constituting 26% of women, were only present in women and not present in men. 42% of the interview symptom phenotypes, constituting 21% of the men, were only present in men and not present in women. It was already noted in previous studies that on the average, women had more symptoms than men at the population level. The probability of overlap of the phenotypes, of the interview symptom phenotypes in women and men, decreased as the number of symptoms in the phenotypes increased. For the overlap, the odds ratios accompanying one symptom increase was 0.85 for women and 0.94 for men. So as the symptom, a phenotype with more symptoms in it was more likely to be either unique to either men or women. So we did some subgroup analyses, and this is a very busy slide, and we're still working through this. But I just wanted to show you, we subgrouped according to STEMI or non-STEMI, whether they received urgent or emergent PCI or not, whether the patients had atypical chest pain noted in the abstracted record or not, whether they had a delay from symptom onset to presentation of greater than 6 hours or less than 6 hours, and whether they had diabetes or not. Women were disproportionately distributed in each of these categories. They're more likely to have non-STEMIs, more likely not to receive PCI, more likely to have atypical chest pain, more likely to have a delay from symptom onset to presentation, and more likely to have a history of diabetes. Among the patients with the more straightforward diagnoses, the patients with STEMI, the patients with typical chest pain, there was still this difference between women and men. But the ones where the diagnosis was a little bit more vague, non-STEMIs, patients who didn't get the immediate PCI, patients who were described as having atypical chest pain, and patients who have a symptom delay, the difference between women and men disappeared. So it was as if the men sort of caught up with the women in terms of the range and the variability of their symptom phenotypes. We're still working through this. I think there's a whole lot that we can tease out in this. So conclusions from this Virgo analysis. Women, first of all, there's an enormous amount of variability. And as far as we know, this is the first time that anybody has ever looked at how symptoms aggregate at the individual level among patients with acute myocardial infarction, or for that matter, for any diagnosis. We look at it at the population level, which is interesting and it's helpful, but it's actually not the way we see patients. And so it seems like looking at these phenotypes at the individual level might be helpful. Women exhibited substantially more variation in unique symptom phenotypes than men. The increased variation in women could be a cause of diagnostic confusion. And maybe that's a cognitive psychology reason for why we are more likely to miss the diagnosis of acute myocardial infarction in women. It may have important implications for how we teach and how we improve clinicians' ability to recognize the diagnosis of AMI. So I told you that making a diagnosis was a two-part process. First part is this hypothesis generation, and so this whole thing about how we store exemplars, how we recognize phenotypes has potential importance here. The second part is hypothesis testing. We use Bayesian reasoning for this. We come up with a pretest probability for all of these diagnostic possibilities, and then we start to test, and then we modify our initial base rate to come up with a post-test probability. So I developed, so I got to know this guy, Jeff Norman. Jeff Norman is from McMaster University, and that's the home of evidence-based medicine. They randomize everything up there. And he was telling me that, I like your book, but I'm not sure that, you can really teach this stuff. And I said, well, I think I can. And so we got to talking about it, and we decided that we would do a randomized controlled trial. And so we did this randomized controlled trial of whether I can teach medical Bayesian reasoning to medical students. We randomized students to 3 conditions. A video of me, it's an 18-minute video of me talking about Bayesian reasoning, versus another arm where we gave them examples. And Jeff thought, repeated examples, they would get it with repeated examples. So we gave them repeated examples of 3 diagnoses, pulmonary embolus, heart failure, and acute coronary syndromes, to try to give them some experience and see whether that made a difference in their ability to revise their probability estimates using Bayesian reasoning. And the third arm basically got no instruction. They got some a little sort of content information about the 3 diagnoses, but they got no instruction on medical reasoning. And so we gave a quiz of 20 questions to all of these students. We asked them what their pretest probability was, and then we asked them, then we gave them the test result, and we gave them either a negative test result or a positive test result, and then we asked them what their post-test probability was. And so what we were trying to see is how far was their estimate of the post-test probability from the calculated post-test probability based on their own pretest probability, but calculated using Bayes' rule. So how good were they at Bayesian updating? So this is a flow chart that shows our randomized controlled trial. We enrolled 65 students at both schools. Ended up 61 of them completed both the learning and the testing phase. And so 61 students, fairly equally distributed, became the study group. So what were the concepts that I was trying to teach? Well, first of all, there's an order of operations in making a diagnosis. The order of operations is you come up with a hypothesis first, then you test the hypothesis. You don't start sending off tests without coming up with a hypothesis. You do it in a deliberate way. This is, by the way we do science. We come up with a hypothesis and then examine the hypothesis. And to think about the probability, there's a heuristic that we can use called anchoring and adjusting. Anchoring and adjusting has sort of gotten bad press by Kahneman and others, but actually it's a useful thing because it forces you to create an anchor, which is your base rate, and then adjust based on the strength of any new information that you might add. And so to measure the strength of new information, I taught them about likelihood ratios. You see, when it comes from my book and from the chapter in Brownwald, when we make a diagnosis, we set this line of demarcation that sets the limit between a positive and negative test. And depending upon where we set that line of demarcation, you can change the sensitivity and specificity. So I think the words sensitivity and specificity are kind of hard words because they don't really tell you what's going on. Sensitivity, specificity, positive predictive value, and negative predictive value are four terms that we throw around a lot. The denominator in all 4 of those terms is different. Okay, and so it's hard to keep these things in your head. So I think for sensitivity, the better term is the true positive rate, and for specificity, a better term is the true negative rate, because depending upon where you draw the line of demarcation, it's the point on this cumulative probability curve that determines the sensitivity and specificity. But better yet, likelihood ratios are dimensionless numbers. You don't have to remember what's in the numerator and the denominator. A positive likelihood ratio is the true positive rate divided by the false positive rate. Okay, and so it's your hit rate divided by your miss rate. And it's on roughly a scale of 1 to 10, it gives you an idea of how strong new information is. So it's a very handy thing once you get to use it. We use the anchoring and adjusting heuristic, and this sort of shows how we do this. We set a pretest probability down here on the x-axis, and depending upon where you choose, then you move up to either this point for a negative test or this point for a positive test, and then you move over to the y-axis to read your posterior or post-test probability. So anchoring and adjusting, depending upon how strong a test is, it depends upon how much you adjust to read off the y-axis to figure out what your post-test probability is. And so this is an example of likelihood ratios. Some tests the likelihood ratio is very strong, a positive likelihood ratio is very strong, such as congestion on a chest X-ray for heart failure. This likelihood ratio is off the charts. If it's there, you can count on that being heart failure. If it's not there, you can't, because the negative likelihood ratio is not that strong. And so you should shift your thinking dramatically if you see that. You can remember this with the mnemonic. It's because congestion on your chest X-ray is very highly specific. So the mnemonic spin, a test that's highly specific, if positive, is good for ruling something in. A D-dimer is the opposite. The positive likelihood ratio is kind of weak, but the negative likelihood ratio is extremely strong. That's because it's a highly sensitive test, and you can remember that with the mnemonic. A test that's highly sensitive, if negative, is good for ruling something out. So these are the concepts that I tried to convey in my 18-minute video. So we asked them 20 questions about the post-test probability. The questions were related to the 3 diagnoses that we gave them in the learning examples, but also we asked them additional questions about a new diagnosis, pneumonia, to see whether there was a transfer of the concept to a new diagnosis. And so the question was, how far was the post-test probability estimate from the calculated value? The first thing we noticed, and we'll just direct your attention to this panel here, is all of the students did much better than we have expected based on the prior cognitive psychology research on how we are at natural Bayesians. So this shows the pretest probability estimate that they gave. This is their post-test probability estimate, and this is the calculated post-test probability using Bayes' rule. And you can see for all the positive tests, they did very well. For the negative tests, they were a little conservative. They didn't quite do as well, but they did actually remarkably well, remarkably much better than you have expected. And this occurred both in the learning questions and also the questions related to that new diagnosis, pneumonia. So how close were they to the mark, depending upon which experimental arm that were they in? They were, so this shows the negative test results, and this shows the positive test results. They were closer for the negative test results, but it didn't reach statistical significance. They kind of overshot for the positive test results, and it was much closer to the mark, and this was highly statistically significant for the positive questions. So what we wanted to do is we wanted to combine the negative and positive questions to look at them all together. And so what we did is for a negative test result, you're going to adjust your probability estimate downward. And so if you miss the mark, the difference between where you should have been is going to be positive. And so if we just simply change the sign on all of these responses, we can combine them with a positive, and we can look at them all together. So how close were they to the mark when you combine them all together? Well, the concept was highly statistically significant. The participants that were randomized to the concept, to my 18-minute video, did a much better job at getting closer to the mark on Bayesian reasoning. And if you look at the learning cases versus the new cases, it was particularly evident in the new cases. It was a trend, but not significant in the learned cases. But the difference between the concept group, the experience group, and the control group was dramatically different in the new questions based on the new case. So suggesting that the concept helped them transfer that concept to analyzing new cases. How about timing? This is all done on this computer platform, so we knew the timing of every click that they did. And so we knew how long it took them to respond to the questions. The people in the concept group did respond significantly longer than the experience or control, but it was only 25 seconds on the average. And so there was no way that they were actually calculating the post-test probability. They were just intuitively thinking about it, thinking about the concept, and then coming up with their answers. So conclusions from this teaching study. First of all participants in this study did much better than expected in estimating the post-test probability. It's possible that the setup of the study just alerted them to the task that they're at hand, as opposed to prior studies in the cognitive psychology literature where they sort of randomly walked into a test. The instruction on the concepts of Bayesian updating improved participants' ability to estimate post-test probability. And the effective instruction appeared to transfer from familiar case to new cases. So reasoning can be taught. It's thought that reasoning is something that you just get experientially, and it's domain specific, and it really can't be taught, but it appears that it can. And Richard Nesbitt thinks that at Michigan has shown in other settings that intuitive statistics actually can be taught. So what are the take-home messages from these two studies that we did on diagnostic reasoning? First of all, from the exemplar study that we did in the Virgo registry, one thing that I tell students and residents that I work with is make the most of your experience. Seek feedback and try to label every patient with a diagnosis, because you want to actively create that store of exemplars that you'll be using to make diagnoses in the future. The other thing is variation. There's enormous variation in the phenotypes, and the variation may be greater in women than men. Be aware of that. That may be a trap that you could fall into if you don't take that into account, and be aware of that. And in terms of the Bayesian updating, try to develop good thinking habits. Using the anchoring and adjusting heuristic as a way of informal Bayesian reasoning will help you, it will force you to think about the base rate and avoid something called base rate neglect, where you don't think about the base rate, you just respond to a test result. And likelihood ratios are very good for calibrating your intuitive estimates. Finally, just a reminder about the differential diagnosis is also very important, and for that we use abductive reasoning. So kind of getting back to my book, you might be wondering why I put a chambered nautilus on the front of my book on medical reasoning. It's an example of mathematical order and regularity in nature, and so I think that science ends up, it tries to find the regularity in nature, and then we apply that science of medicine that's gained at the population level, we apply that science to individual patients. We turn our probability estimates into a degree of belief about our particular patient that we're seeing. And so our thinking has consequences. So thinking about our thinking is probably a pretty good idea. Thinking about how we train people to think. It's not indoctrinating people. It's not telling people, you must do it this way, but at least giving us some pointers on how you might be able to go about it. It's much like a math teacher. Teach people how to approach problems. I think we can do a little bit better job. Good thinking habits will enable us to achieve good outcomes more reliably. When I was here at Yale, I was exposed to this guy, Alvin Feinstein, who was he was a giant here when I was here, and he said this. He said, "For improvement, clinicians must begin to respect the importance of their own thinking." In Alvin Feinstein's view, all of this that I told you about likelihood ratios and pretest probability, he said this is our basic science. For clinicians, this is our basic science, and we should be teaching that type of basic science. So it was a privilege to work with Alvin Feinstein and be exposed to him, and maybe that was sort of what got me started thinking about this. So I can't tell you how much of a privilege it is to be here, what a joy it is to be here for me, to talk to you today, and to be back here at Yale. So I'll stop there, and we'll have time for questions.